Welcome to the Emergency Care Improvement Programme webinar series, which covers a range of topics to support delivery of urgent emergency care services across the health and social care system. Although designed to support the 28 ESIP sites, information contained within these webinars is relevant and open to all, so please feel free to share with your colleagues. Today's webinar, titled Discharge to Assess, will be delivered by Jane Ives, who is the Director of Operations at South Warwickshire NHS Foundation Trust. Before we start, we have a couple of housekeeping points. To note that the session is being recorded and the recording will be available to view on our website shortly. All attendees will be muted to avoid background noise during the recording. And at the end of the presentation, there'll be an opportunity for you to ask Jane questions. If you have a question, please use the raise your hand option in the panel on the right hand side of your screen. Alternatively, you can write your question in the questions section on the panel. And during the Q&A session, we'll unmute you so you can ask your question in person. Thank you for your patience, and I'll now hand you over to Jane. Thank you, Jane.
Thank you, Lisa. I'm going to talk this afternoon around this presentation called Our Journey to Discharge to Assess. There's two reasons for calling it that. One is that it absolutely has been a journey. This has been over a number of years of working together with partners. I guess the slightly misleading thing about that is almost that it feels like we've arrived at a destination, and I think we've still got quite a lot further to go. So at the end of the presentation, I will talk about what next and what our next steps are around this. So we've gone quite a long way down this road, but we're not fully there yet. I'm going to talk about what we've done. I'm going to talk about how we've done it and what the impact on that has been. Primarily, I'm going to talk about two pathways. There are three, and I'll get into some of the detail on that. Pathway 1 is a pathway home, and pathway 3 is a step down to nursing home beds for ongoing assessment. So I'll primarily talk about those two things, but touch on pathway 2. I'm also going to try and give you some top tips as we go through about some things that are really important that have made this work. But before then, just really a little bit of context about Warwickshire, and just to give you a feel for the patch that we're covering. So Warwickshire is a strange shaped county. It has one county council. It has 3 clinical commissioning groups. There are 3 acute hospital providers, one in the north, which is George Eliot Hospital. There's Coventry is in this middle section with Rugby Hospital here across in Rugby, and then South Warwickshire, where Warwick Hospital is in the south of the county. There's one vertically integrated provider one community provider, which is us, but we are vertically integrated in the south of the county, and there are particular frailty challenges in South Warwickshire, and again that drives some of what we've been doing. And across this patch, as in everywhere, there are financial challenges. Particularly in the other parts of the county. In terms of South Warwickshire, we are just clinging on to financial balance with our fingertips, and part of what I'm talking about is that isn't coincidental. Some of these pathways are much more cost efficient. So really this takes us back a little while to really 2011 when TCS happened, and in 2011, 2012 we had got enormous hospital pressures, the kind that are being seen right across the NHS at the moment. We have similar problems to others in terms of the ageing population, the financial challenges we all have, but also a recognition that there is duplication and there is inefficiency in what we're doing, and we wanted to really get at that to see what we could do to make a difference. from my point of view as Director of Operations of the organisation, and but certainly of the acute hospital in Warwick, for me there was a huge driver around the levels of stress that we were seeing with staff, with the A&E performance issues that we had, and the impact on patients, which is certainly our mortality rates were higher than they should have been, and a whole range of major incident type events that we were calling to manage the bed crisis. So clearly, what we were doing wasn't working, and we also had a rising challenge of the ageing population and the financial challenges coming. I also, so really, I guess that's by way of context. The other part of context is that this is on the base that what I'm talking about today is part of a wider system transformation plan, where those top hexagons are around the 3 pathways under discharge to assess and trusted assessment I'm really going to talk about. But we were doing quite a lot in the hospital in terms of today's work today and driving ambulatory care, doing a lot around frailty work at the front end, and working with our community services around integrating health and social care teams around GP practices. So whilst I will give you some metrics around what the impact of this has been, it's the impact of really the whole system transformation plan. I guess the other thing to say is that looking at that plan, it looks like a plan we designed at the beginning, and the slide I've just put up is a slide of what our system of discharge to assess is. And it looks like a fully formed plan, and I guess really what I wanted to say was we didn't start off with this blueprint. This is quite retrospective in a way that looks back at what we've developed and what we've evolved over time. So I think these are the right things to do, but I wouldn't claim that we started out with a fully formed plan. It's been much more evolutionary than that. Before starting on the what we've done and how we've done it, I really want to just go through this slide so that you understand how this system works, because I think when you can see the end point, we can then start to go through what how we got there. So our starting criteria is at the top, which is our belief that no patient who unless they've got acute care needs, should be in an acute hospital. We should be reserving that very expensive resource for those that need it, and to make sure it's available absolutely when they need it, and not 12 hours after their 10-day leave. And so we've segmented the patients who don't need acute hospital care into, well, it says 3 pathways here, there's probably 4, because I guess pathway 0 is those who can just go home with no support at all. But for those who aren't on that very simple discharge pathway, we've segmented it into 3 areas. So the first one is for patients who can be cared for safely at home. There are 2 services currently that support that pathway. There's the Intermediate Care Service with its CERT, which is the Community Emergency Response Team response, so a more responsive service that can mobilise within 2 hours. And then the Reablement Service, which is managed through the local county council. Those 2 services work together, and at the end I'll talk about our next steps for those 2 services. They both provide free care for patients up to 6 weeks, and that pathway, I'll talk about how we've developed it. The next pathway I'm going to talk about is pathway 3, and that's because pathway 2 is a bit more complicated, so I'll give you that afterwards. So pathway 3, this is for patients who are unable to return home, they have very complex care needs, and they may need continuing healthcare funding. So these are patients who we may or may not have checklisted them at the stage they go into the pathway. Often we have, but they are patients who primarily are checklisting in for a continuing healthcare assessment. And there are commissioned nursing home beds for those patients to go into, again, for up to 6 weeks. So that once all of that assessment's been done in that more appropriate environment, then the decision's made for their next step. And then pathway 2 is for patients who are unable to return home, and I guess the context of that is in Warwickshire we don't have any night sitting or mobile night services. So this would include some patients who within our current system would have night needs that couldn't be met in pathway 1, and that's something that we're looking at and others have gone further with. At the moment there are 2 areas for that. We have some community hospital beds, and we have some temporary residential home beds which are commissioned through the council, and those round about up to 4 weeks. So all patients can go through one of these pathways. So no patient is excluded. So those with cognitive impairment, those with significant dementia, still would not be excluded from these pathways, and I think that's an important point. This red bar across the diagram is important because what we agree with patients once they go into these pathways, particularly pathway 1 and pathway 3, is there's a very explicit understanding for patients that there is an end point to the pathway, and at that point, following assessment, the patient will move on to their next care setting, and the funding source will change. Much of that will go into self-funding, or patients will self-care and won't require funding. But at the other end, at pathway 3, that could be CHC-funded care, local authority-funded care, or self-funded care, because in pathway 3 there are a very small number of patients who go home, and again I will touch on that in more detail. So in a sense that's the whole system. It's for and we make it inclusive for all patients depending on capacity. So that's our current system, and so I'll take us back now to right to the beginning of how we developed this. So we started off in the first couple of years with really looking at pathway 1. How do we really provide a service that means that patients can go home and be supported at home and have their assessment at home rather than staying in hospital. During that time, we were also developing our trusted assessment. And we were, but we were also continuing to use winter pressures funding in a very traditional ways with spot purchase, which was really quite ineffective. So this covers the first couple of years and covers pathway 1. In parallel, 2 services were developing. So the Warwickshire Reablement Service, where for the council there was a real drive to support patients to reduce their level of care needs, get them reable to the point where they could self-care as much as they possibly could, and then do the assessment at the end of that time. The referrals were coming from about 40% from the acute, about 40% from our community teams, and the other 20% from the wider community and the social care community team. So that's where the patients were arriving from. And you can see on the slide some of the detail around what the impact of that was. So for patients, as they went through their reablement journey, they were having around about 14 to 15 hours of care per week per client. At the end of that time, they were having around 10 hours, those that remained with reablement, but 50% of those customers didn't have any home care requirements at the end of that time. So the actual amount of need from the patients who went into reablement ended up being 5 hours per week, and that has been a very very effective service for Warwickshire County Council. So at the same time, across North Warwickshire, there was a redesign of that service. There was a 20-bedded community hospital which was closed, and that was reinvested in community capacity to build up that the CERT team, the Community Emergency Response Team, so that intermediate care had got a much quicker and more effective response. They developed an in-reach service into the George Eliot Hospital with their community and the social care teams working really well together, and they also put some input into A&E. They set themselves a standard of 5 a day, so expecting 5 patients a day to move through into the community service. And it was really a pull-through model of hospital discharge with and this was a 7-day service from 8:30 in the morning until midnight. So really quite a significant reinvestment from the closure of the community hospital. I guess one of the learning points I've got here is around whether these systems should be pull or push, and I haven't really got an answer for that. But what has happened is that when this service was set up initially, that 5 a day was being those 5 patients were being identified and were coming into that service. Over time, the numbers of patients have drifted down, and we're working very closely with George Eliot Hospital to try and work that through and understand why not. And it's something around the ward staff who need to really be identifying the patients, and then the community staff in there to really support them coming out. And it needs to be, I think, a combination of both a pull from the community, but there has to be also a push from the hospital side. And I think it's some of the push side that we've lost over time, and so those are things that we're working on at the moment. However, this was extremely successful, and so we said, we've done that pilot in North Warwickshire, we know that it works, we've done some learning, so let's transfer that model to South Warwickshire, where the populations are quite significantly different, particularly with the elderly challenge. And so again, the same tack was taken, though there wasn't an actual community hospital closed. A third of the community hospital beds that were in place historically, and really they were there really because they'd historically been there. So we closed a third of the beds and reinvested again in that community team capacity. The actual capacity increase, and now I'm going to start talking just about South Warwickshire, where the full model's gone in, because in North Warwickshire the full model isn't in place with the more complex arrangement of different providers and commissioners. But the capacity increase from the number of patients that we were able to discharge into community hospitals, and we're able to step up from the community hospitals, increased from 25 patients a week to 85 patients a week once we'd reinvested that money in the community. So there is a real argument for really understanding what your investment in what types of capacity gives you in terms of patient flow and real capacity. So that service was developed and has been in place across South Warwickshire now since 2012-13, and again continues to be successful. I'm just going to touch on trusted assessment and again a little bit of our journey across the last 4 years with that. So we started off with a number of areas. So and again, many other areas are doing this and are starting to do this. So We started off with restarts of packages of care. So any patient who came in, if they required the same package of care on their assessment on the ward, we started off with that any patients within 7 days of their admission, then within 10 days, and we're now at 14 days. And we started off with just our discharge coordinators, team, our discharge planners managed that, and now that's moved to the ward team. So there's a lot more trust in the system that the ward teams are quite capable of assessing those patients, restarting the package of care without referral to social workers, and social care are happy to accept those patients up to 14 days, and that's a significant amount of duplication that we are removing from our social care colleagues. The other area that we developed our trust assessment was around direct referral to reablement. So again, those referrals initially through the discharge coordination team, they wouldn't need to go through the hospital social work team, direct referral to reablement, and we've now moved that on to our OT team, who are out on the wards and are very well placed to do those direct referrals. And to achieve that, we've also developed a little piece of software we call the electronic common assessment tool, which just makes that assessment work, and it does it in an electronic way and shoots from one system to another with the data sharing agreements in place for that. I guess my tip around this, and there is something around starting small. So we started this with a very small group of staff who were involved in this, and over time we really built confidence in the teams, we built confidence in the organisations, and then we've been able to expand it to many more staff who are involved in trusted assessment, but we have taken our time to do that to make sure the confidence is there, and it's again an important feature of our system now, which we continue to build on. So really that brings us up to about 2013-14, where all of that really good work had gone on with those community-based changes, but we continue to have very significant pressures in the A&E, although it was slightly improved. And we had real excess hospital stays for those who were unable to go home on pathway 1, and we started to really look at what we were trying to do, so that we could start with this principle of that no decisions are made about long-term care needs being made in hospital, and putting in a system that would deliver that. But how do we go about doing that? Because that's not something that Swift as a provider organisation could do on its own. So we developed a group of organisations with the local CCG, with the county council and ourselves, and we developed a shared purpose, which was a documented recognition of what we were all trying to do, and the key points are on the slide. What was also important in this is that we asked the local head of adult care for social care to chair our delivery group. So in a way, really, that it was important that the council and local authority were very much involved, particularly around because of their reablement service, but also seen as an unbiased person in terms of how we then got the funding together between provider and commissioner in health. And I think that was something that worked incredibly well, putting that unbiased chair into our group, because this is not easy to deliver when we're all faced with financial challenges. So we put in our shared purpose, and we talked quite a lot about understanding the risk to be managed, and these are a few points that I guess we talked around. But part of it is around the benefits, but they don't always accrue to where the cost is involved. So I guess that means that if the CCG were funding all of the discharge to assess beds, and the provider trust, us, was benefiting from being able to close down capacity and reduce our costs. We needed to really understand that, so that we could come to an agreement around how we worked through how this would be funded. The other thing to recognise is commissioner cost, i.e. price tariff, is not the same as provider cost. Actually, what the cost of care is, and again we explored that around. So we really looked around this whole area of risk share and gain share. I guess it's important though that I believe if there's too much detail in this planning of trying to really work out to every penny where the cost and benefit is going to come out, then you can get stuck in the mire with this. There is something of a leap of faith and something of developing that trust, and we agreed that first of all that there was a block contract for emergency care for the provider, so that protected the commissioner to a large degree as part of this. So those are some things that we were thinking about, and then the practicality of getting on and actually commissioning the pilot. So this was putting in place 30 nursing home beds that were going to run this pathway, and so the funding was joint between the CCG and the provider. So we both put up 50%. At that point, it was going to be 1.4 million for the year, and we asked the council to commission the beds for us using their expertise. So whilst we didn't have an absolute nuts and bolts contract for this, we did have a memorandum of understanding which made it clear around how we would manage the risk and everybody's role and responsibilities. And again, that was an important document. I've talked about the county council. They did commission the beds because they understood that market in a way that we weren't able to, and they were really able to assess who was ready, what the quality of the providers were, and they didn't want to, and they were very clear about how they wouldn't destabilise the market or stifle continuing health care flow, particularly for those on fast track pathways. So a huge amount of detail involved in putting all of that together, and this took us about 9 months to go through all of this detail. And the last thing was procuring the medical support, which was primary care based, which the CCG did. So, having commissioned the pilot and gotten the beds in place, we started to transfer patients who were assessed as Pathway 3 patients into the beds. And there are some things that are important. I've seen some areas in the country where they've set up these sort of schemes and then it's become very blocked, and it's important that the flow is maintained through those beds, that they are indeed only up to a maximum of 6 weeks. So there are a number of things that we have learnt. The care coordination of these patients is really important, and something that we did in Warwick a long time ago was really invested in our discharge coordinators team. So we have a team of 7 discharge coordinators for a hospital of 400 beds. So we really have invested in that team as experts, and it is that team that provide the care coordination for these patients, with these patients and their families throughout the whole pathway, and that continuity. So they're speaking to the same team, same person, is critical, because the written information that the patients get that when they consent to go through the pathway is very clear about the end of the pathway and what happens. So we have got their sign up right at the beginning. There's a weekly MDT in the nursing home, and continuity of staff is very important in that. And again, the quality of the medical model, the quality of the GPs has been fantastic in really leading that MDT and maintaining the flow. So my tip around that is there has to be continuity, and they really have to own that pathway and understand why it's so important. Otherwise, commission capacity can just get blocked very easily, and it doesn't do the job. I'm just going on to just what the size of this pathway is. It's often something I'm asked. So how much of which bit do we need? So this is for South Warwickshire, and this is for a population of 250,000 people. And on that is just the numbers of patients into flow. We get through those pathways each week. Obviously, with a higher number through pathway 1. These and those are just in pathway 1. Those are just the ones who are discharged from the acute. That doesn't include patients being stepped up into that certain reopenment service. So that's the size that it is. Is it right-sized? I'll come back to that at the end, and how we've evaluated that, which is part of our next step. So, what's been the how have we evaluated how these pathways work? We've evaluated along cost and flow, patient outcomes, quality, and something around the culture and what's been happening within our organisation. So I will just talk us through that. This slide, I don't want to be confusing, so I've talked a little bit about pathway 2, which is around our community hospitals and moving on beds, which are the county council beds as well. But in these commissioned 30 beds, we also put some pathway 2 patients. So whilst we were building up the service, if we didn't have enough pathway 3 patients, some pathway 2 patients, so those who are waiting for rehabilitation, and really that's what they need, and our objective is for them to go home. We put those through these pathways as well. So this is pathway 2, but it's through the commissioned 30 beds, just so there isn't any misunderstanding about that. So, and this now deals with nearly 500 patients who've been through these pathways. So the vast majority are pathway 3, and I'll spend more time talking about pathway 3. But I'll just explain how the slide works. This first half of the slide on the left is these are unsuccessful referrals. So these are patients who were referred to the service and for a variety of reasons didn't go through the pathway. That may have been because there wasn't the right capacity, so they ended up staying in hospital for longer. It may have been because the patient or their relative refused. It could have been because they refused because the nursing home bed was in the locality that was further away from home for them. So a variety of reasons, but there are 124 patients who were eligible for the pathway, but were unsuccessful referrals. So what we've done is we've gone through pathway 2 and pathway 3 and said what was their length of stay for those patients. What was the discharge destination? So how many went home, how many went into the nursing residential home, how many died, and there were some other destinations as well. And in terms of the post-discharge care, how many were under local authority funded care, and what was the average cost per week? How many were under continuing healthcare funded care as a percentage, and what was the average? And then I've divided that out between the pathway 2s and the pathway 3. So that's just how this slide works. So then this is the accepted referrals. So 300 120 patients, and this works in exactly the same way. So what we'll see is for the pathway 2 patients, there was a slightly longer length of stay than if they stayed in their acute bed. For the pathway 3 patients, there was a nearly 2-week increase in the total length of stay. We absolutely expected that to happen because, of course, whilst the patient's in the acute hospital, what we're doing is we are rushing to get those assessments done. And our hypothesis was if we did the assessment at the right time and in the right place, then we would see some reduction in ongoing care costs. So we absolutely expected to see an increase in length of stay because we were deliberately giving patients a little more time for us to do the assessment at the right time. So again, discharge destination, and again, I think what's important to point here is before the patient was discharged on both pathways, we're getting quite a significant death rate, and that is really, it's a demonstration of the frailty of these patients, and they are at the end of life. We have tracked these patients through for 12 months following their discharge, and what we have and what we've found is that over 80% of patients have died within the first 12 months. Interestingly, both for pathway 2 and for pathway 3, which was a surprise that so many of the pathway 2 patients were also had died in that 12-month period. So again, our big differences are that so we actually had a reduction in the numbers of patients who were going into local authority funded care, and we had a very significant reduction in those patients who were going into continuing healthcare funded care from 44% to 24%. And again, it's been divided back out into pathway 2 and pathway 3 and the differences in cost. So my apologies that the slide's a little bit busy. But there's quite a lot of detail there, and as I say, what we've done, this gives us what happened at the point of discharge. We have also taken this through, say, for 12 months following discharge for all of these patients, and we've looked at what's happened to them afterwards, as I say, and part of that is the death rate, and through that we've been able to find our costs a lot on the longer term. So the cost of this 30-bed model for the full year is £1.6 million. The savings to commissioners of the excess bed day savings has equated to 1.2 million, and that's really the difference between this 57 days here and the 31 days here. So there's really quite a large, although not equivalent, excess bed day saving. The saving to continuing healthcare for the ongoing costs of those patients, say, and noting that very high death rate is just 880,000, and there are savings to the local authority, and again those have both been tracked for 12 months. We are just re-looking at that at the moment. There may be slight refinement of those figures, but I'm pretty confident those are the level of savings that we're going to be looking at. So that's really in terms of evaluation for those pathways and what we've done in tracking the patients. The next section really, and so what's happened to our system, and I won't go through the detail of this, but it's made a big difference. So our A&E performance has gone up, and I'll just go back to that slide at the beginning. There's lots of other things we've been doing around urgent care flows and not just discharge to assess, and so this relates to all of those things and not just this model, but it is a key part. So we've seen big reductions in length of stay. We've seen and certainly in terms of the quality metrics, reductions in medical outliers, huge reduction in moving patients around the hospital, outlying patients into surgical wards from medical wards, and some reductions in falls in hospital. So a very significant system change based on the system changes that we've been putting in place. So for me, the key commissioner messages are that there is an extended length of stay in pathway 3, so therefore their actual pathway costs are higher because it's cheaper than if the extended stay was in an acute hospital for the whole length of time, and that's something around those two cohorts of patients. It's not an exact match. Is not an RCT, so we just need to be slightly careful about making the direct comparison. But we have seen a big reduction in CHC funded care between those cohorts, and we haven't seen a shift to local authority funded care. Now, some of that is because there is a huge shift to self-funding, and the locality that we serve is one that's quite affluent. So in a more deprived population, there may be more of a shift to local authority funded care. However, my suggestion would be that would be ultimately cheaper to the overall health and care system. So I think an absolute concentration on system costs rather than provider costs and commissioner costs is critical to systems getting themselves in the right place to take that leap of faith and start to put in some of these new models. A little bit on culture, so there's no doubt there's been a much closer working relationship. There's been a lot of constructive challenge, but you know it has been constructive. There is less blame between sectors now, much more proactive working together, and so a lot of the things we've been doing have been, a lot of things we're now doing are building on the trust that we've been building up. It's important that we've had staff engagement at all levels as we've been putting this in, and has been important. Perhaps one of the things I should have said at the beginning was I think one of the things about the model that's very helpful is it's very simple to understand, and that's meant that we've been able to really engage staff in a very practical way. Another part is around the nursing home market. It's been fascinating. They didn't get involved just based on cost. The amount that we're paying per week for these beds is between £850 and £950, depending on the provider and whether it's for dementia or not. And not all of the nursing homes that we start with have stayed the course. We have made some swaps as we've learnt with them around that. But it has been positive for the nursing home market. I'd like to spend just the last 5 minutes just going through what we're doing now. And oh, sorry, I'm just going through lessons learned. I forgot about that. So the lessons learned. So I think one of the things that we didn't do is we didn't size this problem and the solution at the beginning, and I'm going to go through what we've been doing since. As I said, understand the cost to the system, and I think including the human cost to patients as well. It's not all about the money. Shared purpose was critical. The time is important to build our capacity up in these systems and to build the capability of staff and the trust between staff and organisations. As I say, for nursing homes, it needed more time and attention than we first recognised to really make sure that was working as well as it could do. And the last thing is we did attempt to put in pathway 2 in some residential home capacity and release some more community hospital beds, and we failed to do that. I'm probably running out of time, so I won't go through too much detail of that, but I'm happy to answer questions. So to reshape your system, what do you need to know? And we didn't do this at the beginning. We did it last year, and I would suggest to anybody that they do this. So we did a whole system point prevalence audit last year, and we looked at every patient in an acute bed, in the community bed, within our CERT team, within our reablement teams, and within the discharge to assess pathway 2s and pathway 3s, pathway 2s including community hospitals, etc. And we looked at every patient and said, should they be here, and where should their care needs be met? And you can see on each of those bars, so if I just take the top row as an example, for those 300 odd patients, over 100 could and should have been in another care setting. So when we reshuffled our system and said, if magically all of those patients were in the right place, what would happen? And we have over 100 too many acute beds. We have more or less the right amount of community beds. We've got a few. We've got 6. We have 7 too many. Interesting, our community teams in CERT and reablement have more or less the right amount of capacity. Their problem is, though, they're holding many patients in that bar at the bottom, patients who could could be transferred to a package of care. They finish their assessment, and a significant problem we had 12 months ago, and which has grown in terms of our home care market for package of care. So really understanding where your patient cohort could be. Or where your patient cohort should be if they all moved on the day to where their care needs could be met. And that's really driven the next part of our journey, because when we looked at what the average weekly costs of all of those areas were, it's all done on very average costs, and we put the patients in the right place, the cost of provision for that cohort of patients was nearly £10 million a year less. So there are really big savings to be had in getting the capacity in the right place and at the right cost. So next steps for us building on that. So we are revisiting that system snapshot in 4 weeks time to see where we are now, and that will help us to review our pathway 1, 2 and 3 capacity. The second part is that pathway 1, we are integrating those services under a Section 75 agreement for reablement, CERT, intermediate care, and that is active at the moment. We have a shadow management structure in place at the moment, and we should have Section 75 by the end of this summer. And we've rebadged it Home First because we felt that was a more helpful term, and we can relaunch our integrated service. And the third thing we're doing is really developing those pathway 2 services. And we're having another look at extra care housing. We're having another look at residential home capacity and why our intention to commission residential home beds for this cohort of patients didn't work. So that's really the steps that we'll be taking over the next 12 months. So sorry to rattle through the last bit. I became aware of the time. So I'm very happy to take any questions.
Great, thanks, Jane. We have got a couple of people with questions. Jane Hawklad is the first person. I'll just unmute you, Jane, so you can ask Jane a question in person. Hi, Jane. Can you hear me?
Hi, Jane. I can.
Hi. Yeah, just wondering, and you might have said this somewhere in the middle, but how long the journey's taken? And we're right at the start of this journey. Where do you suggest we start in terms of the 3 pathways?
I do think it's. I think it's really important to do that system snapshot and to really understand what capacity you need and where. I think starting with pathway 1, I think is the right thing to do, because I think getting that home care sorted out so that patients can go home where they possibly can, and trying to do that. One of the things we're doing is we've invested in a frailty assessment unit, and we're trying to turn those frail patients home within 48, 72 hours. So I think if I was starting from the beginning and I could only do one thing, I would start with pathway 1, if that helps.
Thank you. That's really helpful. Thank you.
Okay, thanks, Jane. And another question from Joseph Middleton. Joseph, I'll unmute you now.
Hi, Jason.
Oh, he doesn't have a microphone. If I just read out a question.
Okay.
He's got a couple of questions, actually. So first one, were all 3 pathways rolled out at the same time, and did they start at full capacity, or was there a gradual increase?
Okay. So no, they didn't. We did Pathway 1 first. But we did recruit to it and launch it as a full pathway. So there's a little bit of tapering, but really we launched the full capacity at the same time, obviously just subject to recruitment. For Pathway 3, we started off with 15 beds in one nursing home, and then we built that up to 30 beds across 3 nursing homes over the first 6-9 months of the first pilot year. And we learned a lot from that first nursing home. We were there to sort of not make the same mistakes as we went into the second and third.
Okay, and his other question is, was there a reallocation of resources, i.e. therapy staff, from the acute hospitals to the community?
Oh, that's a lovely question. Because we're an integrated organisation for South Warwickshire, when we, through TCS, we put in a single head of physio and a single head of OT, so they've got responsibility across the acute and community therapy services. Yes, that's absolutely the expectation, is that they, for them to move their resources to where the patients were. That has, of course, been a tricky conversation, and we have had to prime some of that. But yes, it is about pushing that resource back to where the patient's going to be. But it was made easier by being an integrated organisation with a single head of therapy.
Okay, Josie says thank you. We have another question for you, Jane. Nicola Coffington. Nicola, I'll unmute you and you can ask Jane your question in person.
Thank you. Jane, hi. I just had a couple of questions. First of all, in terms of Pathway 3 and the nursing home beds, I might have missed this. What other services, what other needs are met in terms of, is there in reach physio and discharge planning into those settings to enable a sort of as speedy as possible discharge? Although I accept what you're saying about actually the whole point was to allow people more time as well.
Yes, absolutely. So it alludes back to that last question, and we moved therapy resource from the acute into the community to deliver that. So yes, there was where patients required any therapy, we were able to provide it, and that's particularly actually for those Pathway 2 patients who went in. For the Pathway 3 patients, there wasn't a lot of therapy. 60-70% of those patients had quite a significant cognitive impairment and dementia, and weren't necessarily able to engage in much of that. And yes, our discharge coordinator was part of that MDT and spent quite a lot of time at the nursing home. So they were really working between the hospital and the nursing home.
Okay, I've just got one more question, if that's okay. I also wondered, are all of the pathways also accessible as step up from community? So you did mention admission avoidance earlier on. I wondered if all of them were accessible.
Yes. No. Sorry. Yes for Pathway 1 and 2, no for Pathway 3. So yes, for that community-based service, it's the same service that delivers sort of the admission prevention service for primary care or other community services and referrals. So that's absolutely, and reablement obviously provides that service as well to the community, and we are looking to really build on that. For Pathway 2, because most of that is community hospitals, the GPs do have admission rights into those, but it depends on whether there's capacity available. So frequently there won't be the right level of capacity available, and that often is because the patient's delayed and going on to the next, particularly for the moment, going on to package of care, and so. But there's no reason why it can't happen other than capacity. For Pathway 3, no, that's just a step down in the sense of almost pure discharge to assess service, and there isn't a step up into that. We have looked at it, but we haven't really got a mechanism to do it at the moment.
Thank you.
Okay, thank you, Jane. And we've got another question from Sharon Wallace. Sharon, I'll just find you on my list and I'll unmute you. Okay, Sharon, you're unmuted now.
Hello, Sharon.
It may be that Sharon doesn't have a mic either, Jane, so I'll
Okay.
ask Sharon's question
Okay.
for her. She's asked, who is medically responsible for the patients in the beds whilst receiving immediate care or discharge to assess?
It is the GP.
Okay.
It's very clear that it's the GP. They're discharged from hospital care. Okay.
Okay, yeah, that's great. I don't think there are any more questions. I'll just give people a few more seconds. You've got your contact details at the end of your presentation if anybody does think of anything. And the presentation and the recording will be uploaded onto the eSIP website within the next 48 hours. Oh, we have one more question from Jane Hogard again. And Jane's asking, do you pay GPs for the care once discharged? I'll unmute you as well, Jane.
Okay. Yes, we do. This is way over and above their normal services to a nursing home. So the GPs who are commissioned to the nursing homes visit the nursing home every day, and they review. They see all patients on the day, or if it's later in the day, on the following day after admission, and they have a lot of interaction with the family particularly around some of the end of life type discussions, and they also attend and run a weekly MDT. So it's a significant commitment on the GPs, and they always tell me I don't pay them anywhere near enough for it, but they are paid.
Okay,
That's really interesting.
Sorry, Jane.
Sorry, I just said it's really interesting. Thank you.
Yeah.
We have another question. I think we've just got time for one more. Emma Owen. I'll unmute you, Emma, if you're able to ask your question in person. Right, maybe again that Emma doesn't have a mic. Emma's question is, yeah, she hasn't got a mic. What was the majority of that cost spent on?
That the 1.6
million. Yeah, sorry.
Yeah, that related to just for the pathway through. That's for the 30 beds. So in essence, that was the 30 beds and the primary care cost, and we funded the council a little to do the commissioning for us. But it's primarily for the beds. I don't know if that makes sense, but this isn't cheap. But of course, it's cheaper than acute care.
Emma says thank you.
Okay.
I think we're probably just about out of time now, Jane. As I said, if anybody else has got any other questions, your contact details are on the presentation. They'll be uploaded onto the website within 48 hours. And I think just now to say we really appreciate and thank you for your time that you've taken out to provide us with the presentation. And I'm sure there'll be lots more interest to follow.
Okay, you're very welcome.
Thank you.
Thank you.
Thank you.